Hi, third semester. Does my hair look okay? Good morning or afternoon or middle of the night or whenever you're watching this. So one of the first topics we're going to talk about in third semester is going to be EKG, one of my very favorite things to talk about, but it's a lot. So when I was teaching EKG at a lot of hospitals around Southern California, sometimes we would do like a certification class, and it would be 6 weeks where we would have six-hour sessions, and you get certified in basic dysrhythmias at the end of that time. So obviously we don't have that much time. We have 3-hour classes, and we're going to have about 4 classes. But a lot of you are coming in with knowledge that some of the people in those classes didn't have, although I was usually teaching nurses, so they did have some pathophysiology. But we are going to put a lot of information into a short time. So we're going to start at the bottom, but we're going to escalate really quickly for EKG. So we'll just start with something really basic. And a good place to start is just to take a minute and think about the flow of blood through the heart and kind of build up from there. So if you know this and you're like, that's so easy, anybody knows that, well, good. You're very confident to start. But if you forgot a couple of these things, it's good to refresh them. So let's start here where blood is coming out of the left side of the heart. So blood is being squeezed out of the left ventricle, and it's going out to the body, right? So it's oxygenated blood going out to the body, everywhere in your body, and it's going to hit all the capillary beds. And then deoxygenated blood, after that blood is used by the body in every different organ of your body, deoxygenated blood is going to come back into the right side of the heart. So it's going to come in through the superior and inferior vena cava. So we'll just make one of them to make it easy. And it's going to flow down into the first chamber of the heart that we're going to look at, and that is the, which one? Right atria. And a good thing to know about the right atria is that as blood is coming down, there is no valve right here between the blood flowing in and the right atria. So it's just a big open container of blood until you go back and hit a valve somewhere here in venous blood flow. And then from the right atria, the blood is going to flow down into the right ventricle. And we do have a valve, an AV valve right here between the right atria and the right ventricle. So think back, what's the name of that valve on the right side of the heart? That is the tricuspid. I always think tri-right. I don't know why. It doesn't rhyme, but that works for me. Tri-right. So during diastole, which is filling time, this is just one big container of blood. The right ventricle, the right atria, and there's no valve here, so going all the way back until you hit a venous valve, it's just one big container of blood that has all the same blood pressure, all the same hydrostatic pressure at that moment. But then this valve will shut, and the right ventricle is going to squeeze, and it's going to open a valve right here that's going to push the blood forward. So what's the valve moving forward from the right ventricle? It's a semilunar valve. And this one is the pulmonic valve. So we'll put pulm. Okay, and then it's still deoxygenated blood, and it's going to move forward in this large blood vessel, moving towards your lungs, right? Because it has to pick up some oxygen. So here, what is this gigantic blood vessel right here that is moving towards your lungs from the right side of your heart? This is your pulmonary artery. Okay, so the only artery in your body that has deoxygenated blood inside of it. All right, then all this blood goes to your lungs, and it goes into smaller and smaller circulation. So it goes from the pulmonary artery to the arterioles, and it goes down in these little capillary beds, and it's going to drop off the carbon dioxide, and then it's going to pick up oxygen. And now we got oxygenated blood, and it's going to move down into the left side of the heart and come into the left atria, and this big blood vessel that brings it down from the lungs into the left side of the heart is called the, you guessed it, pulmonary vein. I hope the E comes first. I'm terrible at IE words. And just like the right side, there is no valve at the top of the left atrium, the top of the left atrium. And then the blood is going to flow down into the big, muy macho, very muscular left ventricle. We'll put some extra muscles on the left ventricle because it's so big and strong. And there's a valve between the left atrium and the left ventricle. And we all know the name of this valve because it's causing people trouble all the time. And this valve is the mitral valve. So during diastole, when blood is filling on the left side, the mitral valve is open. So during diastole, this is all one big container of blood. All the blood that's in the left ventricle, the left atrium, going up the pulmonary vein. There actually aren't any valves inside the circulation of your lungs. So going all the way back until it hits the pulmonary valve, it would just be one big container of blood, all with the same blood pressure during that time. So when we get to hemodynamic monitoring, that's going to be important to understand. Okay, and then blood is going to be ejected out of the left ventricle through another semilunar valve right here. And that valve is the, what is it? Aortic valve. Because of course, the blood will be sent forward into this big, enormous, gigantic blood vessel that looks like this, which is your aorta. And from there, the blood is going out to your body to be used everywhere, all over your body. All right. So we got the blood coming from your body, falling in through the RA. So during diastole, the valves are open. The AV valves are open. So during diastole, filling should be occurring on both sides of the heart simultaneously. So we got blood coming in from the lungs and from the body. Systemic circulation, we're supposed to call it, right? So we have it coming from systemic circulation and pulmonary circulation, falling into both atria. I can use the plural there. Both AV valves should be open, so it will just keep falling to the bottom of both ventricles. Then the blood will start to fill up, fill up, fill up, fill up, fill up. And then these AV valves are starting to float shut. But right before they're about to shut, right at the very last part of a second before they're about to float shut, both atria are going to have atrial contraction. So they're both going to be triggered electrically to squeeze, and that's what we call atrial kick. So going to squeeze another about quarter to a third of volume, force it down into these ventricles and squeeze them a little bit overly full. Then they would just be by passive filling. And then these valves are going to slam shut. So the ventricles are squeezed, are a little bit stretched out. And that gives them potential energy, because now they really want to snap back. So the blood falls all the way to the bottom. It fills up, fills up, fills up, fills up. Right when these valves are about to close, we have atrial kick, valve slam shut, ventricular systole occurs. The semilunar valves are kind of just like swinging doors, right? So as soon as the pressure on this side is greater then the pressure on the blood vessel on the other side of the door, they'll just open. And the blood will rush out. And then it starts over again. And then as soon as the ventricles empty and the pressure in here decreases, those doors swing back closed. Now, it's all about cardiac output. It's really all about cardiac output. So do you guys remember the formula for cardiac output? It's basically your, let me get a green one. Your something times your something. Do you remember what it is? It is your heart rate. So how many squeezes do you have each minute times your stroke volume, which is how many mLs of blood go out each time you squeeze. That makes sense. So this will be how many mLs come out with each squeeze. How many squeezes do you have per minute? And that should equal how many liters per minute of blood is circulating around your body. That's your cardiac output. And practically everything we do in cardiology is to maximize cardiac output. That's really the end game of everything that we're trying to do in cardiology. We wouldn't even really care about people's heart rhythms that much if it didn't affect their cardiac output. So you'll see when we get to some things like sinus brady, if they don't have any symptoms, we don't do any treatment on them. Or first-degree AV blocks. If they're asymptomatic, sometimes people can come into outpatient surgery, so we do a 12 lead on everyone before their surgery, almost everyone. And we see that they come in, they're a healthy person, they have no cardiac history, they have a first-degree AV block. They probably have had it their whole life. We just do their surgery, we send them home. Because it's not affecting their cardiac output, and unless there's some secondary reason why it's affecting them or it's dangerous to them, we don't do any treatment for it. So we really care when it affects cardiac output. So we need two things to happen in this cycle to have the best cardiac output. Number one, we need synchrony on the right and the left side. We need blood to come in from the systemic and pulmonary circulation simultaneously. We need both atrial kicks to occur at the same time. We need both AV valves to shut at the same time. And we need both ventricular systoles to occur at the same time. People get asynchronous, and then the timing is off. So if you have the right ventricle squeezing, but this valve is shut, then this is going to hit a wall. And then the left atrium doesn't have a valve right here. So now a bunch of blood is being forced into the left atrium. It's getting stretched out. That's going to cause some atrial dysrhythmias. Your atrium doesn't like that. It makes those cells feel unloved. It makes them feel jittery. They start to go into atrial fib. So we need things to be synchronous on the right and the left. So what could cause things like that? Well, there are several different things that could cause it, but the most common reason people get asynchronous on the right and the left is because they get an enlarged left ventricle. And then the timing is off on the right and the left. So especially like just people with coronary artery disease, they've had MIs in the past, they have an enlarged heart for a variety of reasons. So they start getting cardiomyopathies and their LV is enlarged and then they're asynchronous. So some people even have pacemakers just for the specific purpose of bringing their ventricles back into a synchronous diastole or synchronous squeezing. Okay, so we need this to be lined up on the right and the left. That will really contribute to good cardiac output. Then the other thing we need is we need the timing to be correct from the top to the bottom. So we need the valves are almost closed, then we need atrial kick, and then the valves close, and then we have ventricular systole. That's how we need the timing to be. Because this would be a problem if the valves closed first and then you had atrial kick. Because then you'd be putting a lot of pressure on a closed valve. And if that continued to occur 60 to 100 times per minute, 24 hours a day, 7 days a week for years and years and years, well, can you see that after a while that might start to damage your valve, right? So then maybe you need like a valve replacement or something. That's pretty big, dangerous surgery, so we don't want to do that. So we need your timing to be correct from the top to the bottom. What determines that timing? What's triggering atrial kick and allowing a little bit of time in between for the valve to close before the ventricles are triggered to squeeze? That's what EKG is all about. So when we see that little P wave, that's the electrical signal that's going to trigger the atria to squeeze. After the little P wave, there's going to be a flat line that's allowing the AV valves to close. Then there's going to be a big QRS. That's the electrical trigger to cause these ventricles to squeeze. Then we're going to see a T wave that allows the cells of the ventricles to reset and get ready for next time. So EKG is really what allows the timing to be correct in a sequence from the top to the bottom. So we'll look more at that as we learn all the different dysrhythmias and see how it affects this timing, and then what happens to people, and then why they have the symptoms they have when they have these different dysrhythmias. All right, so that's a start. I hope it made sense. And I want you to kind of look at this diagram and make sure that you know the things that we talked about on it, and I will see you guys soon.